talking to you with the background of what we do with patients, how we follow them, what we're looking for, and why we're looking at the entire system, of which telomeres are a big portion of it now. So the overview will be to give you the background of age management, precision age management, which is what I like to call it. I didn't term the word. It came out of Harvard, actually, a place up a little north of Yale. And it was termed by Dr., I think, Jerome Gruberman, who wrote The Way Doctors Think, which is a fascinating book. If none of you have read it, I would encourage you to read it because it's the way medicine should be practiced. Then I'm going to talk a little bit about the emergence of age management physicians and why age management. I'm going to touch on some of our clients and patients very briefly, and then there'll be some concluding remarks as well as I'll be part of the Q&A. So the target is obviously optimal health for life. We want to achieve healthy longevity. It's not enough to live a long life. We've seen the outcomes. We have a lot of seniors living way beyond, 80 even, and the hospitals are full, the critical care units are overflowing, and there's actually not enough care to go around. So you can just imagine the fear of the aging baby boomers growing in just the same way and getting all the diseases we see so common today that I believe are disorders of aging, not diseases. And so how do we attain, sustain, and maintain health? How can we identify people's health assets and liabilities, set up priorities, establish some kind of process, and then mostly motivate and have people invest in their own health? So one concept is that we have legal and financial counsel, but we don't have medical advisors. So how do we guide patients when the time is so short? And for a general internist and most doctors who see primary care patients, they're seeing at least 20 patients a day and sometimes 40 patients a day. And it's only going to get more difficult, whoever becomes president. So coordinating access is an important concept that I think needs to be part of the future of medicine. There are limited resources, which I just touched on, for aging boomers and their families. And I believe that there's a lot of knowledge out there, but unfortunately everything on the internet glows, but isn't always correct. So that interpreting that knowledge and having the wisdom to do so requires guidance and teaching and getting to know the individual who is your patient. So I feel that this is an emerging field of medicine, and this is a graph of what I've been seeing for the last decade or so. I don't know how many of you in the audience know what a hospitalist is, by raising your hands. So most of the audience, but you'd be surprised when I ask most people, I would say 50% of them actually know what a hospitalist is. And a hospitalist has taken over the critical care unless a practice has a full-time doctor who's in the hospital, or doctors share the care of patients in the hospital, because unlike when I trained many, many years ago, doctors were able to follow their own patients, stay involved, and in today's, not only the time limitations, but the advances in technology in a hospital almost make it impossible for a primary care doctor to keep up. So hopefully there are close ties, and that's at that end of the scale. In between are all the primary care and acute care. Not just primary care stands here for primary care as well, specialists and all the other types of doctors we're all familiar with. And at the beginning here, as I term age management medicine doctors, they optimize and advise and help guide sort of care. And there are several doctors who are doing this in New York and around the country. You might have seen that I use the word clients instead of patients because I don't like to think of people as sick. Why should they get sick? As far as I'm concerned, you can detect disease way before it emerges. We don't wake up one morning typically as a diabetic. We do sometimes get a heart attack, but that's because we haven't been paying attention, or we haven't gotten the right screening, or lived the right lifestyle, or all of the above. So the disease has not yet emerged, but it doesn't mean it can't be tackled. Symptoms are probably present, but they're unrecognized, they may be undiagnosed, compensated, explained by aging or stress. So there's opportunities in this field that I think the future of medicine, including telomeres and keeping our DNA as long as possible. We look at all abnormalities and we want to address critical findings as soon as possible. There are many patients that we've had where we've picked up leukemia years before they would have known they had it, or prostate cancer, or they were on the verge of a heart attack or a stroke, and sometimes, unfortunately, we'd see their lab results, and before we got to meet them, they actually were hospitalized with a stroke or a heart attack. We all know about Tim Russert. I think he's more well known than most presidents in today's world. And he died suddenly of a major MI, and we all looked at him every Sunday and probably thought to ourselves, wow, you know, he looks like he's a walking heart attack, and a wonderful guy, but you know, he probably doesn't get enough exercise, doesn't eat the right kinds of food, stress to the max. And unfortunately, he did die, and the workup and the investigation that happened before really put a small, if no dent, in the quality of his life. So age management to me is a powerful concept in that recent medical research shows that while we inherit genetic potential, we don't inherit genetic certainty. I'd advise all of you to read 2 books that came out in the last 6 months, one by Eric Topol and the other by David Agus. They're joint co-founders of a company called Navigenics, which I'll touch on, which has just been purchased by Life Technology. But basically, it's the notion that medicine is changing and the way we're going to be working with patients is very different. And genetics, per se, is not a recipe. It's just ingredients. And there's now data, very extensive data collected, that shows that connection, that you can, for example, if you have a heart attack gene like 9p21, and you're even homozygous for it, by eating tons of raw fruits and vegetables, you can actually reverse your risk to that of somebody who doesn't have that gene marker or that SNP. 65% of our health issues are actually determined by environment, so I'm sure many of you have heard the term genetics loads the gun, environment pulls the trigger. So changes in lifestyle, diet, medical intervention, metabolic and hormonal modulation can have a positive impact on the aging process. We do a number of tests, and they're too extensive to go into detail, but I am going to touch briefly on each category. So first, we look at routine comprehensive testing, lab testing, a little more extensively than you might see in a regular routine annual, because I don't feel that you really see all the relationships in an annual kind of evaluation that's typical for a primary care doctor. We do aggressive cardiovascular screening through lipid profiles and sometimes CT scans if they're warranted. We do something called VO2 assessment, which is oxygenation. We do something called endopat, which looks at endothelial function that actually correlates with cardiac catheterizations and CT angiograms in terms of the effect of inflammation on the lining of the endothelium, something that I think is a common denominator in the pathway to disease, inflammation more than just cholesterol. We also look at body composition and bone density over time, and we're doing genetic screening as well as telomere measurements. This is one such example, JD, a 53-year-old gentleman from Buffalo, who over a short period of time, and he's been our patient since '09, had this body composition done in January 2010. As you see, the first part, upper part of the graph, and the second part of the graph, the next column, the third column, is, let me just see if we have so this is September 8th, 2010. And you can see here he put on 10.9 pounds of muscle and lost 5 pounds of fat. So this is not an uncommon finding in our patients as we begin to modulate and balance their system. This isn't giving them too much medication or too little or too much supplements. We look at individuals and then use them as their own controls. I have a fairly deep background. In fact, most of my background is in clinical research at Yale and at the National Institutes of Health. And so in the beginning, when you first learn how to use something and what drugs are going to make a difference or tools are going to make a difference, you start very slow. You look at patients compared to themselves. Ultimately, you have to do big, powerfully statistical, relevant studies, but in this case, we're starting off looking at change over time to see if it's cumulative, and we can appreciate it. This is one of our women patients who was seen also in January 2010, put on 9.5 pounds of muscle, lost 2.5 pounds of fat, actually called us in this period to complain she was gaining weight, and until we did the body comp, we could show her that it was fat, which is what we want. The key question that we asked her is, do your clothes fit the same way? And generally the answer will be no. Actually, they're looser around the belly, and notice a difference. So Okay, VO2 testing. The guy you see on this slide here is Livingston Miller. He's actually, who was my trainer, and his story was such that I got to know him over a period of a few months, and he started telling me that over the past couple of years, he'd been admitted several times for passing out. And he was very thirsty all the time, and he went to the bathroom a lot, and he just thought he was dehydrated. And so in the hospital, they would frequently work him up, mostly a neurological workup. And nobody asked him a vital question, a simple genetic question. I think of family history as a poor man's genetic test. And they didn't ask him, well, is anyone else in your family a diabetic? They even saw slightly elevated sugars, but they assumed it was because he had just eaten. It turns out that he actually had already sustained a heart attack. And when he came into the office, Stephen Villagomez, who's not here tonight, who's an exercise physiologist on the team, along with Tim Coyle, who is here, ran back to say his VO2, his oxygen use per minute, was very low for someone who should be in such great shape. In fact, the picture you're looking at was up in Grand Central Station because he was used as a model of health. His heart rate was pretty high, and his METs were very low. METs which is a metabolic equivalent in terms of life expectancy, actually coordinates with it. METs of 5 are high risk for death. And here he was looking in the prime of life at 52, yet he wasn't healthy at all. This is a picture of our current lab. You actually see Stephen right here, Tim here, and one of our current patients running on the machine. Actually, with thanks to Brent and Janet and Laura today, these slides would not be here, so they were helping. There was a team effort to get this done. So we have assessments that we do. We look at levels of health, and we're able to monitor that over time. The VO2 testing directly measures oxygen uptake and provides a way to distinguish between an improvement in mechanical efficiency and an actual physiological training effect. So I want to show you what happened to Livingston, but first I'll mention this is a superb paper for any of you who want to see why this is much more revealing than your routine stress test, which will simply be positive or negative, or sometimes falsely positive or falsely negative, because this actually measures the metabolic equivalent. And each one met, as I said, and it's from the New England Journal, I think in 2002, each one met increased exercise capacity conferred a 12% improvement in survival. So exercise capacity is used as a very powerful predictor of mortality among men than any established risk factors for cardiovascular disease. And there are many more papers, but this is one of the early papers that I thought was excellent. This is Livingston after about 5 months, and you can see with appropriate management of what turned out to be diabetes with a hemoglobin A1C of 6.1. At that point, 6 was what we were told that 6 was borderline. We actually now, it's been kind of rotated down to 5.7 as the normal bell curve shifts, because we're measuring normals who generally have high risk of diabetes, high risk of heart disease. And so all the curves over the last 3 decades, for all of you who are old enough to know this, have shifted to lower and lower and tighter numbers. But you can see what happened with Livingston. He improved his oxygen saturation from 23 to 33.8, and his METs went up, so he had a 36% increase in survival based on that in 5 months. And he completely actually reversed the diabetes. Unfortunately, as I mentioned, he already had a sustained heart attack, because as soon as we saw that finding, Stephen and I referred him back to his doctor at NYU. He had a nuclear stress test, and he had already had disease present. But he's doing well. He's lost an incredible amount of weight. He said that around his middle, even though he looked good, he knew he didn't feel right. And so on the course of treatment over the last 4 years, he's done very well. This is the machine I referred to, the EndoPat. I don't know how widely it's used. It's actually, for the doctors in the audience, there's actually a code for it, so it is covered by insurance. And you can actually measure in a 15, 30-minute period the health of the lining of the endometrium, how much inflammation is there, and therefore how well does it fill after occlusion. We use both arms, and we occlude one arm with a normal blood pressure cuff, and we measure pulse on the tips of 2 fingers on each hand, 1 finger on each hand. And as we reinflate it, you can see that in a normal endothelial function, there's a hyperemic effect where there's a super effect here. But in someone who has dysfunction already, it doesn't respond in that same way. This is a sign of peripheral vascular disease that relates completely to coronary disease, to cerebral disease, and so it's a critical way to follow patients. It doesn't need any extensive kind of diagnostics, and you can do it right in your own office, actually. This is one of our patients, a fairly young gentleman who came in, and we knew that he was not very healthy, and you can see that he had abnormal findings. He had a very, he had a very low test. I think his RHI, which is reactive hyperemic index, in terms of his ability to respond once his arm was occluded briefly for, I think, 5 minutes, was not that healthy. And I'm getting mixed up with the, yeah, you can see that he didn't have this hyperemic effect, and his score was only 1.33. And the score needs to be greater than 2 in a fasting state, no caffeine for 6 hours, no food for 3 hours, although water, in order to be assessed normal. And then we go on to work with patients with the hope of improving this. This is a picture of this gentleman, and you could see that he had a CT calcium score, which wasn't too bad, actually. It was 42, and he was 25% of his age and gender, meaning 75% of males at his age would have a higher calcium score. His angiogram did show plaque everywhere. All the arteries were involved, and the PDA was just small, but everything had between 20 and 50% plaque, as you can see here. His numbers weren't too bad. When we looked at his lipo profile, this is using the NMR, he actually had looked pretty good. He had slightly elevated small LDL particles here. He was on a statin. I believe he was on Lipitor or Crestor at the time. But his particle sizes were large, which is good. That's favorable. But the thing that was really disconcerting is that he also had a very high sensitivity cardiac CRP, which is an inflammatory marker that in his case was not a good thing. This is some more lipoprotein profiles. I just want to show you how important it is not to accept the surface of cholesterol markers, but you can see here that this gentleman who came to us MF on, I think, 20 milligrams of Lipitor, he looked really good. This is total cholesterol, triglycerides, HDL. His HDL was a little on the lower side, but when you look deeper into his particles, it's all red. Red is bad, green is good, yellow isn't too bad. And so even though in a routine evaluation that looked like he was fine, it really wasn't fine. The small particles were still there. We really weren't doing much. Nowadays, you can actually dig even deeper, and very recently we started using Berkeley Heart Labs, which allows you to look at genetic markers to see if statins would make a difference, and if they did make a difference, would you use them? Aspirin and all the rest of it are also there, as well as many other markers that we are looking at. So in this particular gentleman, you can see how bad, how high his particles were, how bad his good cholesterol, how low it was, and that he had small particle size. We switched him to Crestor, and he's done very well on it. Again, this is a notion that you can extend age management medicine into the genetic testing, and why would you want to do that? Well, I think of medicine now as precision age management medicine, because I feel that we can more precisely treat individuals by learning more details about who they are, their lifestyle, the family history, which I started doing 20 years ago in anticipation of actually genetic markers. I thought, wow, when we got genetic markers, I wouldn't have to do all this detailed work and drive myself crazy and the rest of my team by looking at all the factors and evaluating it. And I was wrong there. My team has heard me say this a number of times, because the genetic factors just give you risk and probability. They don't really tell you what's going to happen. So they're important, but unfortunately, we still have to do the heavy lifting, as do our patients. So we look at metabolism, lifestyle, genetics, and more. We work with specialists, and we then work with family, and this is an important component piece about how you can push back prevention of disease even into families. So there are a number of ways of collecting samples. You can do buccal smears, which is shown on the bottom here. You can collect saliva. I just mentioned a few different companies here. This is not an advertisement for any one company, and in fact, Navigenics, which is no longer doing this kind of test, they had developed it with Mayo, are that's the one we actually had used. What you get is a number of markers, and you see the orange in this particular gentleman, and some of them are 0 to 1% and others are 50 to 100%. Well, that's because there's a much higher probability that diabetes, osteoarthritis, obesity, and heart attacks will happen, while there's a lower probability of brain aneurysm and Crohn's disease. So we're able to work with patients, particularly when we have patients who say, I'm doing everything right, and we look at their genetic markers, and if nothing shows up as a risk factor, we're kind of suspect that maybe they're not doing everything right, or maybe it's stress. So it's a way to help guide decision making. These are what we look at. I'm sure many of you have seen these kind of results, but you look at SNPs and you look where changes are in association with disease. So if there's a change in one of the basic amino acids, C, G, T, or A, for those of you who are remembering Watson and Crick, you will look at risk, you will be able to determine that there's risk present, and that's what we're doing. Actually, David Agus's book, The End of Illness, is the one you might want to read to hear about the futuristic practice, where he's actually hypothesizing that a drop of blood will be able to tell us what's going on in your system alone by looking at the proteins that are circulating. If you continue here, we see that this is a couple I just picked out of our patient pool. The wife, MX, was homozygous for the 9p21 gene, which gave her a very high risk of heart attack. And her husband, BX, was a 58-year-old male, she was 52, homozygous for MTHFR, which we actually did, and it was the C677T, which is associated with an elevated risk of arteriosclerosis and blood clots, and we actually did that through Quest. We hadn't studied him through saliva yet. And when we looked at their makeup, the markers actually of his wife here, you can see, just so I can explain it slightly, 9p21, the risk marker is G, so she had GG, and that put her at high risk, odds ratio of 1.72. This was published in Science 2007. She did not have the marker for MTHFR, and she had A, and it's the GG marker as well, so it had no risk conferred, no additional risk, and this is based on New England Journal of Medicine. So the reason I liked to do this is that there are studies, and I alluded to this one, that shows that you can actually change these variants and decrease risk of disease in populations who may have these risks labeled on their genes. So this was a large-scale trial, multi-ethnic, and I think it was over 3,800 cases, 4,200 controls, and the risk of MI and CVD conferred by chromosome 9p21 SNPs appeared to be modified by the prudent diet high in raw vegetables and fruit. So one of the things, this is Mendelian, for those of you who want to remember back to high school biology, but they have 3 sons ranging in age from 14 to 21. So per Mendelian genetics, each one will inherit at least one MTHFR, C677T, and one 9p21. So you can see the mix here. And so looking at that, why not start when they're teens or even younger to correct this deficit, to not lay down plaque or have inflammation? So that's the kind of thinking we're doing. This is one of our patients who has been a patient for several years. We like to use EB because he had told us that he had never been out without his shirt from the time he was a teenager because he didn't like his body. He was very overweight at 6 feet. He was 235 pounds. He did limited golf and swimming. He consumed a glass of alcohol a day. He was a smoker of 1 pack per day in the past for 5 years, but he had quit several years before. He was married for 2.5 years, no children, but without contraception. He noted decreased libido, he's only 38, erectile function, decrease in energy, and the weight gain. He had a positive family history of CVD in his father, cardiovascular disease, high blood pressure, cancer in grandparents, arthritis, hernia, alcohol use, alcoholics actually, both of his parents, smoking, Alzheimer's, and arrhythmias, Epstein-Barr, and thyroid disorder. So when he first came to us, you can see that his numbers didn't look really good. He was actually hypoglycemic, reactive hypoglycemia, which is not uncommon, but it's not as common as a lot of people think they have it, that their jitteriness means they need to eat sugar. They're probably not eating right, and that's what's happening. And that's what was happening with him. So he had a fasting sugar of 46, which made him feel jittery. But he had a high hemoglobin A1C of 5.6, which put him borderline 5.7, now being a pre-diabetic. His triglycerides were quite high, his carbs were probably out of control. His LDL was somewhat high. Homocysteine was very high, 12.5. Cardiac CRP was 4. His vitamin D3 was 38. His cortisol was fine at 7.9. And then you could see what happened. This is, I think, a year later. You could appreciate that practically everything has normalized here in the way we would want it to be. He was very strict about what he did. He really, after a July 4th kind of big party, he said to us, I'm not starting, but he was seen in June. He said, I'm not doing anything until I have my big party in July 4th. And then afterwards, he hit the ground running, and he really has just gone from strength to strength. This is his cholesterol range, and again, you can appreciate they were out of range. Look at his small particles, and his HDL wasn't too bad. And if you look at what happened later, he improved to some degree. He still had a small pattern, actually, as things were continuing. His size dropped a little, which we can see, but his number of particles had also dropped significantly. And then there was one more about a year later, or now a year, 6 months ago, no, a year and a half ago, sorry, that shows that he's completely within range. This is a picture of Eric, which I think, I don't know if the lights inhibit it, but I think it's probably appreciated the change over time. And this is just a lateral view. So I'm going to skip this because I think I touched on it, but this is just a change in 1 year that you're seeing in a film here, that while dramatic, and I'm glad that he was willing to have his picture used, it's not really the change that we're most excited about. We're most excited about what happens internally, because we know we've reversed disease, that he is going to be healthier for much longer. Not only does he feel well and can live life to the fullest, but his body can keep up with him. And now I'm going to turn to telomeres just to wrap up. I think you've heard a lot more, and certainly Bill and Mike know a lot more than I do, but these are the bright spots that are the telomeres. You saw a vivid production of it from both Noel and Bill. We know what they do. We've heard it. So they allow the cells to replicate, so I'm not going to bore you with this. Short telomeres, I have a shorter list than Bill. He's been around far longer in the field, but there's a lot of diseases that are associated with short telomeres. Again, they shorten with age, so they shorten, cellular age is also, cell division will stop ultimately. We know what telomerase is. So we can see the telomere shorten with time. I think this is, well, the reversal, I think, happens here. But there was no noise. So this is one of our patients who's been also around for a few years. He's actually 69 years old. He was born in 1943. The graphs on the next slide will show you his telomere growth. Now, this is all that we had available was repeat labs in Vancouver, so it is not specifically the short telomeres. If you want to talk about the laboratory ways of measuring it, Bill and Cal, of course, and Mike, and almost everybody but me would be able to give you many more details about the assays in the labs. But suffice it to say that we're looking at average size telomeres. But I decided, with the background in clinical research, that I wasn't going to subject people to this, including myself, unless I had a way to monitor it. So we've been collecting data and saving aliquots from the first year we started, which was just about the end of 2009. And you can see, although I don't know how well appreciated it is here, that this is 2010, January, April of 2011, and then April of 2012, when Marvin went from 66 to 67 to 68, and his telomeres got longer and longer, which was better and better, of course, despite his aging chronological age, 5.8 to 6 to 7.0, 7.4 for the granulocytes. The lymphocytes is the other white blood cell, mostly known to fight viral diseases and cancer, very loosely, very broadly speaking, and granulocytes, more like bacterial infections, also lengthened, 7.4, 7.6. 8.2. I was pretty amazed in the first 4 patients, of which I was one. The 2 that had the most dramatic response were cytomegalic virus positive. So the study that had come out was actually true to form. I had no expectations. In fact, I told every single patient that not to expect to see any change at all, because the nature of it is it would take a long time, given the lack of sensitivity of this assay, to see that kind of change. So this is what it looked like. This is homegrown, thanks to Brent and I think and Janet and Laura, but you can see that there's increase from a lower percentile to a higher percentile for the lymphocytes, which are up here, and these are the granulocytes, and the same thing are here. And then if you look at change over time, which we just looked at his mean size, so you could better appreciate it, you could see what happened with the length, the mean telomere length for lymphocytes for this gentleman. And then you could see what happened for the granulocytes, which is continuing to be studied. Again, aliquots are being saved, so should we decide to run it in any other technique, like either telome health when that becomes available, or life length, which we've begun to do several months ago when we were able to get samples to Spain. So we're excited about that. We just collected the number of patients that we could find very quickly, literally done in the last 24 hours. And you could appreciate that there was change over, so in this, the first person, which happens to be me, 6.56 to 6.9. Then there are several other patients along here. And you can see with almost, without exception, there was growth, particularly the positives. Here are the 2 positives. Here's another 3 positives, and there's 1, 2, 3 negatives, and pretty much across the board, with some exception. And sometimes what we've seen in some patients, a decrease, in part lifestyle, things were going on. Of course, we can only assume that. We don't know that absolutely. We're only using these patients as their own controls. And this is the granulocyte, the mean telomere length as well, and you can see the change here, a negative CMV. I never got exposed to cytomegalic virus, going to 7.6, and the others pretty much going up across the board. It didn't make sense. We were going to do averages, but actually it's based on age specifically, so it wouldn't have made sense. I will say that for me, personally, anecdotally, I found within 6 or 7 months, I was totally ignoring it, but I went back to Yale to get my eyes examined by the same ophthalmologist I had seen for 20 years, and he said, your eyes are changing in a way that I don't expect to see. So I had completely kind of forgotten about what I was doing. He said, are you using your reading glasses? And I said, actually not, and I had them everywhere. And I realized it was the one change I made, because I kind of use myself a little bit as a guinea pig, and I'll only do one change at a time to see if I can detect anything going on for an extended period. And I just went back again 2.5 years later to a new optometrist who has no clue. The first ophthalmologist at Yale said, okay, what are you doing now? So I told him about it. But this guy had no idea and was not interested. And he said, oh, they must have gotten your glasses wrong, as he gave me weaker glasses and told me that I didn't need the strength, that somebody else must have measured me incorrectly. So I had actually a note from him, but I didn't have time to include it here. Okay, I just mentioned life length. We don't have the data that's really, that we could use, but I think that that's going to be something that's going to be interesting for the future, and we certainly will want to go head to head with all the different ways to look at length. This just came out in Brain Behavior and Immunity, and I think it speaks to the work that's being done by Cal Harley and Elizabeth Blackburn, who are developing telome health that will, again, measure telomeres in a different way than Maria Blascow is in Madrid. And this data is particularly interesting. There's this study that just came out in August, but there's another study that came out 2 years ago. And it absolutely shows that there's a relationship with the number of inflammatory particles like IL-6. If you increase omega-3s in patients at high risk with cardiovascular disease and you measure their telomeres over time, they're longer in patients who were taking the omega-3s versus the patients who were not, and they had decreased markers of inflammation, one of them being interleukin-6. I think this one, yeah, Elizabeth is, and she's mentioned as a co-author on both of these papers, and I think the original work was done this was published in JAMA in 2010. So I think of what we're doing, including measuring telomeres and trying our best to lengthen them. Hopefully Bill's theory and everybody else's is correct here. We'll be doing the best we can to avoid emerging disease. That we create an individualized plan for each human being because we're all different, even identical twins. I didn't have time to include data here, but my twin is positive for things I'm negative for. Actually, even in our genetic makeup, she has 2 SNPs that are positive for diabetes, and I only have 1. So the whole field of epigenetics and the relationship between the spirals of DNA, that I don't know how many of you saw these recent papers out of Nature, showing that our assumptions were completely wrong, that 80% of DNA is inert. It was coming about because the DNA breaks up, and as such, we don't see the control. And there are actually control switches on and off that can get turned on and off that are close to each other when it's in a spiral form. So this is fascinating work that I think is going to have huge implications for what we do, because if we can indeed change our very genetic makeup by the choices we make, it'll be hard to ignore that. It's easy now to ignore it, but the more we know the details, the more we own about that information, the better we can guide our patients to doing the right thing that will serve them the best so that they can age as healthy as possible. The medical advisor, and we're continuing to adapt. I just included this here as a last little slide that I made up a while ago, looking at the fact that the age management doctor bonds with the patient in some way, but then helps with other doctors, creating teams, consults and refers. And this is one of our favorite people. I heard him mentioned by by Mike earlier, that by Dr. Hayflick. What ultimately does us in is not disease per se, but our declining ability to resist disease. And then one of my favorite authors, Dr. Seuss, has a great poem about if you can live till 103 and not need doctors, if you just had access to the tut-tut tree. So this is a great book if you want to enjoy your old age and not have to live the way the people did in his book. Thank you.